Good morning, everyone. We are so fortunate to have Ella Marie at the Innovation Center and for her to have continued through multiple administrations in doing that work. It's just a gift to all of us. I'm Carole Johnson. I'm the Commissioner of the New Jersey Department of Human Services. That puts me at the intersection of payment and social determinants of health. Our department runs the Medicaid program in the state of New Jersey, as well as the SNAP program, child care, mental health and substance use disorder services, services for individuals with disability, aging, and a host of other services. So I live every day at the intersection of what today's event is about, and so I'm thrilled to be here, both for that reason and also because the opportunity to speak to you about the next iteration of the Future of Nursing report is a huge honor for me. The 2010 report made a difference to me as a policymaker. At the time, I worked for Mary Wakefield, usually, other than Mary Wakefield, I'm usually the biggest advocate for nursing in the room, except for today, I guess. We changed the way we structured federal investment in nursing education and training because of much of the work that you did in that first report. And so I think today's conversation is about how do we take that conversation forward? How do we think about how to create that groundwork for new opportunities going forward? So in thinking about today, I debated whether to talk to you first about the kind of things we're trying to build in New Jersey or about my recommendations for what I hope the panel will consider. Because while Mary is not responsible for the content of my presentation, she is responsible for the fact that I never go anywhere without asking for something. So I thought it might be helpful to start with the recommendations just to frame out so that when I talk to you about what we're doing in New Jersey, you'll understand some of the context within which I think there are opportunities and challenges when it comes to nursing, and we can talk about how to build that going forward. So first, I would say, I'm a huge fan of the IOM. I love the IOM. Their reports, the National Academy of Sciences reports, have been fundamental in changing policy, but the evidence-based standard is going to be too long for me. I'm in my seat for 4 years, 8 years. That's how long I'm in my seat. I don't have time. I need promising practices because I'm willing to take risks, and I need promising practices. And I need you to point me to the kinds of things that you see working, the kinds of places where there are seeds of things that I can model, I can take to scale, I can try to do good work. So, of course, we all live and die by the evidence standard. That's what clinical practice needs to be. But here we're talking about people who are very high risk, living at the intersection of challenging social circumstances and complex medical conditions. I need to move on those folks, and I need to move now, and I need promising practices. Two, I would say, while this report will clearly focus on a host of things, please do not lose your focus on the training pipeline. I'll tell you a story about my experience. I've been in my seat. I've been in Governor Murphy's cabinet for 1.5 years. New Jersey was one of the first states to move to manage long-term services and support. So we do home and community-based services in a comprehensive way, as Ella Marie was talking about. We think about what we can do in the community to help keep our older residents safe in their homes and get the social supports and medical supports that they need so that they don't end up in an institution. I do that based on clinical assessments. I do that with nurses. I have a hard time recruiting. So I, as a person I'm a huge fan of nursing, and I'm looking for all the ways as we go forward to build models that center around nursing. I'm going to keep fighting through that. But what I want to share with you is that other policymakers who have that challenge may think differently about the next thing if they're having challenges implementing the first thing. So please don't lose your focus on building out that pipeline, thinking about how we invest in training, because that matters for our ability to do the next thing. And then the final thing I'll say is that, in terms of recommendations, is really continuing to focus on scope. Scope matters, and I will say that we've been thinking about some creative models in New Jersey that I'll share with you, and I really think APNs are part of the strategy here, and they're the way that we're going to advance things, and we really need to have as much flexibility as possible in order to do that. As a person who has been in a policymaking role for close to 25 years, so before this, I worked in the White House, I worked for HRSA, I worked in the Senate, I worked in the House. You all may disagree with me, but I will say it would be helpful if there was some clarity in the messaging. I can't tell you about the meetings I've had where people say to me, it's a more economic, nurses are going to be more economical for you, they're going to get better outcomes, et cetera, you're going to save money, and then 2 seconds later say we want pay equity. Like, those things are in conflict, so pick which one you want, but like, as a policymaker, I need to hear what you really want. And I think that, that may be a little controversial, but I just, as to share with you as a person who's sat in this seat and been to the other end of these lobbying meetings for the better part of 20 years, that's an issue that I think we need clarity on. So let me tell you a little bit about some of the things that we're trying to do in New Jersey. One, our First Lady has made maternal and infant health outcomes a priority in our state. We are below the national average when it comes to infant mortality, which, the only acceptable answer is 0, but we are below the national average. What happens, though, is when you look below those numbers, we have striking disparities. An infant, a black infant born in our state is 3 times more likely to die than a white infant by their first birthday. That is just unacceptable, and we need to change that. So we are taking aggressive action in that regard. We are implementing a number of policy changes in our Medicaid program. The one that's probably the most relevant for today's conversation is that we are building a perinatal episode of care bundle that is essentially thinking about the full range of services and how we can pay in a way that brings the care team together and that also thinks about health equity, right? So how can our payment model really be a driver of both delivery system reform as well as building those connections to the community services that are part of the solution here, because you all know this better than I do because you see this in clinical practice. The outcomes matter, not just what happens inside the clinical walls, but what happens in the community. And so we're thinking sort of holistically from a payment perspective about how we bring that bundled payment together. We're at the front end of that work, and we're really working to engage stakeholders across our state and helping inform how we might do get to the best possible model there. It's going to take some iteration. We're not going to get it right the first time. It's going to take some testing, but we're really excited about it. We also are expanding Medicaid coverage postnatal. We got some we got additional funding in our budget this year. So right now you can cover the mom for 2 months post-delivery. We're going to try to expand that out to 6 months if CMS will agree with us. We know how important really connecting people and holding on to people post-delivery is. Other things that we're doing in the maternal space is really thinking about our service delivery. We're adding doula services to Medicaid. We are building out we're still working with the legislature on centering and group prenatal visits as part of our strategy. We're really just trying to think about all of those interventions that will help on the services side while we think about payment reform as well. And we're going to stop paying for early elective Cs. We're really, yes. So we're excited about that. We think that there's a comprehensive strategy that we can advance here, and that nurses are part of that solution, and that are part of that. I mean, one of the things that we think about when we think about care coordination is how do you bring the right people around the table? As you think about episodes of care, which is really in the value-based payment lane that Ellen Marie talked about, how do you think about who are the players that need to be at that table? What are the metrics that define success? How do we actually create interim metrics so that we know we're on the right course? Because, look, these are really important and critical moments and critical healthcare decisions, and we need to make sure that we're not waiting for the final outcome, that we have some indicators of success along the way. Another thing that we're working to do is build out our community-based footprint for medication-assisted treatment and opioid use disorder. So we have the federal waiver to do substance use disorder on the inpatient side, which is important, and we are continuing to move forward with that. Our need is so great. We had 3,000 deaths in our state last year. Our need is so great that we know that we need to have community providers who are part of the solution when it comes to the opioid crisis. And so We are taking advantage of the federal change we made in the Obama administration to ensure that NPs and PAs were part of the MAT prescribing. So we are training physicians, NPs and PAs across the state to get their federal waiver to offer MAT. We lifted prior authorization requirements for MAT in our Medicaid program. Yes, that was very popular and necessary. Like, this is a place where when someone's ready for treatment, they need to get treatment, and we don't need to be waiting for that change. We have built out a new Medicaid payment model, and this is when it comes to payment issues, we've thought about the fact that the clinician, the doc, the NP, the PA who's offering the medication-assisted treatment often is not going to be the person who has time to make all those community connections that we know someone who needs to get on a path to recovery needs. So we've built a billable service for navigators alongside the clinical delivery service, so that that office-based physician, we call this our office-based addiction payment model, where we've raised the rate for what the clinician can get paid for the intake and assessment, and then we have built a billable service for navigator services for for the appropriate person in that office to be connecting that individual to social services, to counseling services, to the kinds of things that we know are essential to moving people along the way on a path to recovery. Thank you. And then earlier we heard a little bit about Project ECHO models. We have Project ECHO in our state for medication-assisted treatment, for opioid treatment, but when we pulled clinicians together and asked, like, what are the biggest barriers to care? You all know that I've never been in a conversation where the first thing on that list isn't reimbursement. It's always, reimbursement is the first question always, but we took care of that. What was second on that list was the issue of having support. A lot of people who went through clinical training, other than in the last several years, didn't get a lot of exposure to substance use disorder treatment. And so while Project ECHO is incredibly valuable and we try to use it wherever we can, we have built and funded centers of excellence in opioid treatment in our state who are building a warm referral line so that there's a place you can call to say, when you're willing to start doing medication-assisted treatment, to say, okay, here's what the patient looks like, here's what I'm planning to do you have any advice for me, what are your recommendations? So that clinicians begin to get comfortable providing medication-assisted treatment, and then also to be a referral source for complex patients that it might be better to have in a place with addiction experts. So we're trying to think holistically again here about what are the taking down immediate barriers, getting rid of prior authorization, building up our capacity, getting more people their data waiver, changing the reimbursement structure so that more people are willing to do it, building up our navigator training opportunity. We're also going to start paying for peers in Medicaid. And then really providing the support that clinicians told us they need to be able to offer this kind of treatment. So that's a way that we're thinking about the clinical experience and the clinical experience connecting to the community. But we are not leaving it there. We're also investing we've made, with our Department of Labor, investments in employment services for individuals who have addiction or are family members of individuals who've had addiction, people who basically have struggled in the job market. And we're making investments in supportive housing, because our view is that it's important to get people on the path to recovery, but it's also important to help people sustain recovery. And to sustain recovery, you need to think about what those social determinants are that help people along that path. Now, we may see people who cycle back through our treatment system, but we want to give them every opportunity to be on that path to recovery. So those are some of those investments that we're making to really think about social determinants holistically as we think about a comprehensive strategy on addiction treatment. We also are approaching our Medicaid program with a public health lens. We've taken a bit of a public health lens to where our benefits are. So we thought about, in the last year and a half, we've made changes like lifting the requirement that you had to demonstrate that you had liver disease before people got access to hepatitis C treatment. We're expanding family planning access. We're doing LARC postpartum, which we had not done in our Medicaid program before. We're lifting prior authorization requirements on tobacco cessation. We're really trying to think about where are the barriers, and then how do we engage our community partners in expanding access. So I thank you all for the opportunity to be here and the chance to share some of what we're doing in New Jersey, and really look forward to the next report.